Good evening, everyone. Welcome to tonight's session. Tonight's session is called Perinatal Depression and Anxiety, What's New in Clinical Practice. I'd like to thank everyone for joining us this evening. Before we move forward with tonight's session, I'd just like to do a quick acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the peoples of the Kulin Nation as the traditional custodians of the land on which we're meeting today. We recognise their continuing connection to the land, waters and culture, and would like to pay our respects to elders past, present and emerging. I'd also like to just touch on some quick housekeeping for you all. So at the moment, all attendees should be muted, and we ask that you just remain muted throughout the session. There will be the opportunity for some Q&A at the end of the session, but our presenters tonight will give you the opportunity to unmute yourself at that time. If you do have any questions throughout the session, please use the chat box at the bottom of your screen there. And this will be monitored throughout the session and can be answered at the end in our allotted Q&A time. A reminder that this session is being recorded, and a copy of this recording will be provided to you at the end of this session if you would like to re-watch it. We also ask that you please change your Zoom name. This is for the purpose of our team taking attendance for tonight. And this is used for certificates at the end of the session as well. You may receive a direct message from our education team during the message, just asking you to provide us with your name so your attendance can be recorded successfully. Here's a quick look at tonight's agenda. And tonight's session will, also, before we move on to tonight's session, I would like to just briefly talk to you about health pathways. So some of you may be familiar with Health Pathways Melbourne already, but for those of you that aren't, Health Pathways Melbourne is an online resource written by local GPs for local GPs. It allows GPs to search for a pathway by a condition or symptom, then view best practice steps for assessment and management. Each pathway also includes local up-to-date referral information and resources to help educate patients and involve them in decisions about their care. We'll have more details about the specific pathway for perinatal depression discussed later in the session. And now, finally, moving on to our wonderful speakers tonight. We have Dr. Alan Gemmell, Professor Jeanette Milgram, and Dr. Michelle Byrne. So without further ado, I will pass over to Dr. Alan to begin tonight's session. Thank you, Alan.
Thank you, Hamish. And I think that we have our slides being successfully shared by Jeanette. Well, welcome again to Perinatal Depression and Anxiety, What's New in Clinical Practice. I'm Alan Gemmell. I'm the Director of the Parent Infant Research Institute. We're based in Heidelberg in Melbourne. I'd also just like to begin, next slide please, Jeanette, by paying our own acknowledgement that we are on the land of the Wurundjeri people and pay our respects to their elders, past, present and future. We pay our respects to other elders and to all Aboriginal and Torres Strait Islander peoples. I'll just pass over to my colleagues, Michelle and Jeanette, to introduce themselves, and you'll hear from me again in a little while.
Hello everyone, my name is Michelle Byrne. I'm a clinical psychologist at PIRI. It's lovely to be with you all tonight. To let you know a little bit about me, I coordinate our Bupa Parent and Baby Wellbeing Program and work across several of our randomised control trials at PIRI.
Thanks, Michelle. And I'm Jeanette Milgram, and I'm the Executive Director of PIRI. And there's just a little picture of what PIRI does. We're committed to improving parent and baby wellbeing from conception to 2 years. And the hub of what we do is research. A lot of our research is about developing interventions and assessment and treatments for perinatal depression. And from there, we do training, as you can see, practitioner development, and we also have a model clinic. The work that I'm going to present is obviously not just my work and that of my colleagues here, but we're a small group of clinician researchers, not-for-profit organisation with our own board, and it's that vibrancy that makes what we do, we think, quite relevant because we are hands-on. Oops, it's not moving to the next one. Okay, so we've got a small group today, which is great, because what I was hoping was that you might in the chat put the single most important thing you'd like to learn by the end of our day today. And Hamish, in a bit, I'm going to ask you to summarise it, but Alan's going to talk first, so you've got a minute to put it together. And if you like, tell us what you find most difficult about treating postnatal depression. Now, we skipped this slide, but you've already seen what's today, what the offerings are, because it's just the objectives that were circulated. And so you'll see Alan talking about prevalence, you'll see myself talking about identification and diagnosis, and Michelle talking about risk, really important, and then we'll talk to you about treatment. So I hope you enjoy it, and do ask questions. So I'll pass over to Alan.
Thanks, Jeanette. Perinatal depression, which when we talk about it, we're talking about depression that occurs in pregnancy or in the first year postpartum. It's a serious mental health problem. Next slide, please, Jeanette.
Sorry, Al, this is not, I'm not quite sure why this is doing this.
Mm-hmm.
I don't know if you're expecting this slide next, Al, but you might talk to it.
No.
I'm trying to move all of us so we're not on top of our slides, but
yes.
Yeah, okay.
Wasn't one that I was expecting to.
No.
Look, perinatal depression is a serious mental health problem. It embraces postnatal depression that we see described in this slide, and also antenatal depression, and it has serious negative consequences for women's health and for their quality of life. It's distinguished from baby blues, which, you know, perhaps a majority of women experience for a short time after birth. And in terms of antenatal and postnatal depression, perhaps 20% of women experience symptoms of that kind. A much smaller number experience these low prevalence mental health disorders such as psychosis, which is on the slide there. I don't know if you can get to my actual slides, Jeanette.
Here they are.
Okay.
Andre slipped that one in.
Okay, good on him, just to keep me on my toes.
Exactly.
So just before I do my next bit, I thought it would be useful if people wanted to just reflect for a moment on a couple of quiz questions, the answers to which will be revealed shortly. Just pop them in the chat if you feel so inclined. Off the top of our heads, what do we think are the percentage of cases that go unidentified? Is it less than 15%, 25%, or more than half? Next slide, please, Jeanette. And similarly, what proportion of identified cases do we think receive adequate treatment? Is that 1 out of every 2 women who are identified, 1 in 5, or as little as 1 in 10? Next slide, please, Jeanette. So perinatal depression is highly prevalent. It has profound effects. The good news is it can be treated successfully. Next slide, please, Jeanette. The impact of perinatal depression is long lasting, and in fact, from Australian data, we know that the major burden of that is actually carried by children into the future, in terms of long-term impacts on their future developmental prospects and their own mental health outcomes. Next slide, please, Jeanette. However, what this slide is showing us is that, and it's the answer to the question that I posed a moment ago, more than 50% of cases go unidentified. And while less than half of those that are identified receive any treatment at all, perhaps fewer than 10% of cases receive an adequate evidence-based treatment that results in remission for that person. So they're quite sobering statistics about the poor uptake and the poor reach of treatments that are available and that do have good evidence for their efficacy. Next slide, please, Jeanette. So one way that we can try to improve on that situation is through the use of depression screening tests. In fact, in Australia, the clinical practice guideline recommends that this be done in pregnancy and in the postpartum for all women, and it specifically recommends the Edinburgh Postnatal Depression Scale be used to do that. And by using an instrument like that, we leverage the potential to increase identification rates and, of course, therefore, the number of women who can potentially be offered an effective evidence-based treatment. Next slide, please, Jeanette. Thank you. So successful screening, though, is not just administering a test. Screening needs to be conducted in a well-resourced context, in a coordinated, quality-assured screening programme and system of care that's focused on supporting improved mental health outcomes for those women who are screened. A very central need when applying a screening test is to have a clear policy of always following up and confirming a positive screening result with a further diagnostic investigation. Next slide, please, Jeanette. So the answer to the questions that I posed a few moments ago are that more than half of prevalent cases of perinatal depression continue to go unidentified, despite really quite substantial initiatives over the last decade and more. And next slide, please, Jeanette. Out of 100 women who are suffering from perinatal depression, by the time we deal with non-help seeking, non-recognition, failure to engage with adequate treatment and so forth, only in around 1 in 10 cases does that woman end up receiving an adequate evidence-based treatment from a health professional that results in the remission of her depression. And I think, if we've got our slides in the right order, that the next slide will tell us a little bit about who is vulnerable to perinatal depression. And there are a number of factors that are more frequently seen in women with perinatal depression. These are associations, they're not universal characteristics, but they include commonly a personal or family history of mental health difficulties, traumatic and stressful life events, and a lack of practical emotional financial, social, and especially partner support. Now, I think if we've got our slides in the right order, I'm handing over to Professor Jeanette Milgram.
Thank you. Thanks, Alan. And just before we start, Hamish, did you get any chats in there at all about how close were people to answering the question or what people wanted to hear today?
Thanks, Jeanette. Look, we haven't had any answers to that just yet. I'm sure people might be busy typing away now if they'd like to add something in just whilst I'm talking. I know I'm certainly looking forward to the session ahead and what's to be discussed. So look, if anyone would like to just put something into the chat for us now quickly before Jeanette takes us through the next part of the talk.
That's fine, Hamish. We don't want to put anyone on the spot. It's just hoping that we've targeted the content right. So if anybody was going to say, I'd really like to know about this and we're not covering it, we might wing it and cover that too. So that's the purpose of asking that question. So you can, if you get things you want to say, just interrupt me, Hamish, at any point. So I'll be talking about what you do after screening, really, identification and diagnosis. But first, I'm going to take you back to the case study that you probably haven't had time to absorb very deeply, but we circulated a case study with, and the key points are here with Natasha and her baby Audrey, who's only 16 weeks old, in a well-supported partner relationship. But she does have a history of depression. She, particularly after a stressor, her parents separating, and a family history of depression. And she has current stressors. She has difficulty asking for help, and she yearns to return to pre-baby life. So you've seen more details in the case that was sent to you, if you want to look at it, because we're going to ask you to think about this mum as a focus of what we're presenting and what we might do with her. And what we'll be asking is what do you suggest for further assessment, management, treatment, and we're hoping that we're going to give you a few clues about that. So as Alan said, screening is only the beginning of the story. It's a very important beginning, but it's only the beginning of the story. So we do encourage, currently the guidelines recommend screening. A lot of nurses and GPs do use screening, but we need to move on to diagnostic assessment after that. Do it in the context of broader risk factors, as Alan was describing. There's lots of vulnerabilities in order to decide on a good management plan. Now, I'm glad you showed the health pathways before, because we wanted to put you back there if you don't routinely use the Edinburgh, because it's there in your health pathways and you can find it, and it links you to the COPE site, which were instrumental in coordinating the guidelines. So it's a 10-item screening tool, and as you no doubt know, the threshold is 13 and above. And then there's this question 10, which is a very useful question because it taps suicidal ideation. You can see this, that also there's the other tools which I believe you may use with other forms of depression. So in the perinatal area, really Edinburgh's become the one that people tend to use, but that doesn't mean that the others that you're more familiar with wouldn't be useful. So when we're thinking about perinatal mental health disorders, I've put perinatal depression here in the context of the range. So at the back of your mind, when we're looking at postnatal depression, we're always thinking, well, is it postnatal depression? Could it be something else? High prevalence disorders include the very common comorbid anxiety that we find associated with depression, but we also find a significant proportion of perinatal women who are just anxious, very anxious, and that's very debilitating. The other factors are things to keep at the back of your mind, the low prevalence and the other risk risk issues such as eating disorders, substance use, and always the partner relationship. Now, I keep moving us. So in terms of the frequency of all these different disorders, as Ellen pointed out, baby blues is common, usually transient, sometimes will continue. Here we've got depression postnatally and antenatally around the 10% mark, and anxiety about the same. And it's really important to see how more prevalent they are than your other bipolars or schizophrenia. So that's why we really do focus on those disorders in this presentation. So how do you diagnose? No doubt you're very familiar, but so this is a refresher. It's characterized by the same symptoms as depression at any other life stage. And most commonly, particularly researchers, but many clinicians define postnatal depression according to DSM-5 criteria, because it's so helpful to capture some of the essence of those women who may be more than symptomatic and feeling low, even though that does require management too. And the DSM-5 criteria, again, as a reminder, you need at least 5 symptoms listed below, but you must always have A or B, depressed mood or loss of interest, occurring most days for a 2-week period and representing a change from frequent functioning. So as you can see, these are pretty debilitating symptoms, but they can range from mild, moderate to severe. So as well as a diagnostic category, it's important to be aware of the severity, but not ignore mild symptoms, because for some women, mild symptoms will still benefit from support or a preventive approach. So according to the DSM-5, the onset needs to have occurred in pregnancy or within 4 weeks post-birth. Now, it's really interesting because that is not what clinicians and researchers use as a definition of postnatal depression. So there was a lot of argument when the new DSM-5 was being devised, and lots of input, but it remained there. So the general consensus is that postnatal depression occurs in the first year postpartum. And so, of course, apart from think about other disorders that may be at play, other issues such as sleep deprivation, which mimic some of the symptoms of depression, difficulty sleeping and so on, due to the baby, need to be teased out in order to arrive at a diagnosis or differentiating it from bereavement. And not to forget about thyroid dysfunction and medication, which is your arena, if there's some GPs there. Oh, we've got somebody waiting to be admitted. Okay. So major depression is what we focus on a lot when we talk about postnatal depression, but the less severe form, which is now called depressive disorder with insufficient symptoms, for some of you who use DSM-4, it used to be called minor depression. So the name change, it's almost the same definition. So instead of having 5 symptoms, you got 2, or depressed affect and at least 1 more. So what needs to be remembered is that anxiety is often comorbid, and the most common anxiety disorder is generalized anxiety disorder. Social phobia and simple phobia also seem to rear their head at this time, and being alert to the symptoms of anxiety, and these again are drawn from the DSM-5, and they're often quite easily recognizable, and women will more easily identify themselves as anxious than depressed. Oh, gone into. So as Ellen said, having diagnosed, seeing if, in other words, what I mean is seeing whether somebody who's positive on the EDBRA meets diagnostic criteria. Don't forget to look at personal history, even if there's only mild symptoms, because you're looking at those women who are more likely to become depressed. Now, of course, these are just the big six. When you actually look at the research literature, there's all sorts of other stressors that come up: moving house, stopping, restarting work, concurrent stresses like isolation, and of course, COVID has had a huge impact, hasn't it? So all these, stressors are a big one. Now, the women will not necessarily come in and say, I'm depressed. They often come presenting around their baby or some other, or I'm not sleeping well. And a lot of the women who write poems and then give them to us do so after they've recovered, but they're very telling. And so it's over to you to help those statistics that Ellen presented, to help women divulge and talk about what it's like. No one told me it was going to be like this. No one said it would be so hard. Black mornings, grey days, no appetite, and so much sleep I miss. And the guilt around the effect it has on the baby or the partner. They don't need a burden like this. But with your help, this mother got through it. I found a place where I could go and stay. And that was coming and talking with some of our therapists and have a time out to nurture. And then one day she realized it wasn't going to be so hard. So that's why we're all here, to do that. So if we go back to our case study of Natasha, we see that indeed she has some risk factors, episodes of depression in the past, family history, she has stressors. And so we know that she was at high risk. At this stage, I'm going to hand over to Michelle, who's going to focus in on what affects, because we're dealing with depression, a small number, but a very important number of women. And that is suicidal ideation and risk to the infant. Over to you, Michelle.
Thank you so much, Jeanette. And obviously, when we're thinking about risk before, we're thinking of risk of perinatal depression and mental health concerns, but we also want to be assessing risk to the mother of suicide and infant when we're considering these perimental health difficulties as well. So I wanted to acknowledge that in our webinar today, we are focusing on risk of suicide to the mother and possible risk of harm to the infants. However, it is, I want to acknowledge that important to assess other psychosocial risk factors when we're thinking about safety in the home environment, intimate partner violence and family violence as well. So thinking about a risk assessment, then mother and baby safety is critical. And when we're thinking about screening and assessment, as I've said, of perinatal depression and other perinatal mental health concerns, it's necessary that we're completing a risk assessment to understand the likelihood of the woman harming herself or harming her infants, and then accordingly being able to follow up on a supportive management and treatment plan. So I've listed here that when we are assessing and screening, there is the use of screening measures as well as clinical judgment when we're assessing risk. Some of the commonly used and what's considered to be gold standard screening measures I've detailed here. And this is firstly the Edinburgh Postnatal Depression Scale. So embedded within this screening measure is item number 10 that does give us an indication of whether there is risk if there's a score greater than 0 that the mother has identified of thoughts of self-harm. And we can use this as a starting point to inquire further with the mother. However, I also wanted to acknowledge that other commonly used screening measures, such as the K10 and DAS, don't provide us with an indication of whether there is suicidal thoughts. So depending on what screening measures are used, we can then have follow-up questions with the mother and whether this is a continuation on what's been reported on the Edinburgh or an additional follow-up question. And I've listed an example here of have things felt so bad that you thought a lot about death or ending your life? And so we want to be able to do this sensitively, but to get a good sense of what this risk profile might look like for the mother. So on the next slide, we have 6 key points that we ask about when completing a risk assessment. And so firstly, we want to get a sense of if there is suicidal thoughts or suicidal ideation, how frequently are these occurring, how powerful or intense or persistent are these thoughts, and are they vague or fleeting thoughts, or are there specific thoughts perhaps with a plan that are coming up? So an example question that you might start when you're considering suicidal thoughts is, what exactly have you been thinking? How often is this coming up for you? Do you have a sense of what's triggering these thoughts? And we then want to get a sense of whether there is a specific plan that's occurring for the mother, and the details of that plan as well. So is this something that she's thought out in detail? Is there a timeline associated with this? And if there is a plan that's occurring for the mum, we also want to get a sense of how lethal is the method in regards to the plan. Is there also access to the means to carry out a plan? And does the woman have intention to act on this plan? How likely is she to follow through with this plan? And also considering what are the protective factors. So what are the main reasons for mum wanting to be here? What prevents her from acting on these thoughts? When we're asking these 6 areas of questions, we also want to be considering those psychosocial risk and protective factors that may be occurring for the mother. In particular, we are considering the current situation. And it's when we're thinking about this that we're getting a sense of report and observed mental state. So thinking about the affect of the mum as well as her reported mood. Is there a sense of hopelessness or despair or anger? What's her level of insight, and is there any impairment in her judgment? We also want to be considering whether there's any symptoms of psychosis, hallucinations or delusions. Is there isolation that's occurring for the mother at this time? Is there any other substance use? And then alongside the current situation, these dynamic factors, we're thinking about static risk factors that may be present for the mother as well, and considering what's the history of suicidality for the mother? Have there been past attempts made? And also, is there a family history of suicide or a more recent peer suicide that may have occurred? Importantly, when we are assessing risk for the mum, we also want to be considering the safety and the capacity to care for infant as well. And so when we're thinking about risk or possible risk to infant, we can actually observe the mother-baby interactions. And the information that we're getting is across relationship factors, infant behaviours or concerns. We're thinking about these 2 factors are both what we're observing, whether it's in the clinic or what, now that we're moving to telehealth, what we're hearing, being able to use what we can observe, and then also what's reported by the mother as well. Again, we're considering those psychosocial risk factors that have been touched on by my team, as well as maternal factors. So what's happening, for example, for mum's mental health? Is there a diagnosis of a mental health concern, for example? And what are the protective factors that are present for mum as well? So risk to the infant and the unborn child. It's really important that when we're assessing risk of harm to baby or the unborn child, that we're doing this really sensitively with mum as well. So there can often be a lot of fear and concern about disclosing thoughts of harm to baby. And we know that it's actually quite common for mothers postnatally to experience unwanted, intrusive thoughts of harm coming to baby, whether this is unintended or intentional harm. And there can be a correlation with anxiety and other mental health concerns where this may be prominent as well. So when we're thinking about this, the example questions that we might ask are, have you had any thoughts about harming baby? Have you had any negative thoughts towards baby? Have you felt irritated by your pregnancy or by your baby? And as we're going through these questions with the mum, we want to get a sense of how often this is occurring, when, what are some of the triggers or precipitants, the stresses, and then what is she doing in this moment when this is occurring for her. So it's really helpful to be able to determine how disturbed or distressed is she about these thoughts, and differentiating the distress and anxiety from an intention or a plan to harm baby. So a safety plan, when we're thinking about baby, really depends on these responses. And if we perceive that there's risk of harm to the infant, part of that safety plan might involve other people in the infant's care, such as a co-parent, or if there is higher risk, notification to child protection may be necessary. So I've included on this slide a helpful tool to be able to look at managing risk. So this comes from the Australian Clinical Practice Guidelines for mental health care in the perinatal period through COPE, and they are freely available online and also linked through Health Pathways as well. So it can help us have a bit of a sense of structure around, okay, what am I asking to be able to get a sense of the risk that's present for mum and for infant. So the key areas are listed there, and depending on the responses, it can help us determine what is the risk profile that's present for mum. And we look at this across whether it's low risk, medium risk, or high risk. And then our associated management and treatment plan will be dependent on this risk profile as well. And relatedly, how often we will be following up to reassess risk and who will be involved as part of this management plan. On my next slide, I've got some options that we might consider as a risk management plan. Now, depending on your role, if you're working as a GP, as a nurse, or a psychologist, I understand we have a multidisciplinary team here tonight, which is a real strength as well, will depend on what this looks like in the management plan options. What we've got detailed on this slide focuses on some of the considerations that we might make if there is medium to high risk, but we're making a plan right across those risk profiles as well. So particularly important with the medium to high risk that we're developing a safety management plan, and things that are included within that, we're thinking about warnings, triggers, so warning signs, triggers of these distressing thoughts, for example, coping strategies, and the support team and crisis support numbers that the mother may have. There's also online resources that can support developing a safety management plan. For example, Beyond Blue now have a phone application that can make it handy to be able to use that as a resource. So with, when appropriate with consent, we might be enlisting the family support as part of this plan, or having a shared care plan with a multidisciplinary team. When necessary, we might also involve a CAT team or child protective services. And if there is urgent or imminent risk, we would consider calling 000 and requesting an ambulance to transport to the ED. So a note on referral pathways, our level of risk is going to inform the management and treatment plan as well. And these are some of the options that we do have when considering mum and infant's needs. So the role of psychiatry or psychology through a mental health care plan. There's the option also, if needed or clinically indicated, for an inpatient admission. So there's, we've got mother-baby or parent-baby units that support a high level of risk or severe mental health concerns. And there's also early parenting centres that provide support for mums and babies that are seeking assistance perhaps with settling and feeding to the early parenting centres. We're going to talk a bit more about specialised e-mental health supports today and how this can be a really helpful and evidence-based referral pathway. So through programs such as MumMoodBooster and Mum-to-be-Mood-Booster, and also consideration if mum does have private healthcare through Bupa. PIRI and Bupa have the Parent and Baby Wellbeing Program, which is freely available to mothers who have Bupa hospital cover as well. So just briefly, I want you to reflect on Natasha and Audrey, and to think about, for Natasha, with the information that we have here on the slide and the background information that's being provided to you, what do you think is Natasha's risk profile? And how is it that you have come to this conclusion? And so when I say risk profile, we're thinking, is she a low risk, medium risk, or high risk of suicide, and thinking about harm to baby, to Audrey as well. So I'll give you just a moment to pop those answers, please, in the chat. Don't be shy, and we will be able to continue from there.
Thank you, Michelle. And I guess that what Michelle's asking is, what sort of questions might you want to ask Natasha in order to decide her level of risks based on what Michelle has presented. So any thoughts, but we'll be opening the chat up later to be able to talk about this. So I'm going to move on now to moving away from assessment, diagnosis, and then the time we spent on risk assessment was because very often it's an area that is difficult for some non-mental health clinicians, in the sense that if you're not familiar with asking the questions, but what we've tried to do is to make it clear that really it's a process of questioning and elimination, of trying to make mums feel comfortable talking about it, and that's the way you'll get the best response. Even though it will not come up for the majority of depressed women you see. There might be a low level risk, and you at least want to be able to rule it out and feel comfortable about that, so that you can then decide, well, what am I going to do now? What am I going to treat her with? So I wanted to share with you some of the programs that PIRI has developed. The Getting Ahead of Postnatal Depression program, our face-to-face, and our internet programs, MumMoodBooster and Mum-to-be-Mood-Booster. I'd also like to share with you other considerations when treating postnatal depression. When treating postnatal depression, it's not possible just to be thinking about the woman herself, because it influences both her infant and, if there's a partner, her partner. So we know that now, unfortunately, there are approximately 62% of dysfunctional relationships. And we know that the rate of partner breakdown is higher, particularly with chronic and ongoing postnatal depression. So whilst this isn't the topic of the talk today, I'm just going to very briefly highlight that whenever you're identifying a woman with postnatal depression, keep in mind that there may be a partner who's either distressed themselves and made themselves be depressed, or is finding it quite difficult to know how to support his partner who has depression. And we also know that paternal distress often goes unrecognised. And we also know that it has an impact on the baby, just like the mother's depression, unfortunately, has an impact on the infant. So we know from a lot of research, including quite a lot that we've done ourselves, that there is quite an impact both during the acute phase of depression, of a lowered responsiveness, poorer speech, negative affect, which isn't surprising. I mean, you saw the symptoms and you know the symptoms of depression. How can you be spontaneous and joyful and responsive when you're feeling just so black and so difficult to even get out of bed? But unfortunately, this has an impact on the baby. And by the time of adolescence, there is an association with ongoing developmental problems with children of mothers with postnatal depression. They had elevated risk. And so intervening early, the more you can do immediately, both to help mum get on top of her depression, but also not forget that then there might need to be some attention to the mother-baby relationship. Now, we developed a face-to-face program with a manual quite a long time ago, as you can see. It's about to be republished as an edition because the manual has now been tested in many successive cohorts. And we find that it's a very useful approach. And I'll just tell you a tiny bit about this psychological approach. It's cognitive behavioural therapy, and we now have a number of Cochrane reviews that conclude that cognitive behavioural therapy is effective not just for depression in general, but in the perinatal period. And our program looks like, in some ways, any other depression treatment, but it's not. It's been tailored for women who are depressed. So the easiest way to make that clear is with our session 3. Like, we don't ask women to, why don't you lie down for 3 times a day, do some relaxation, tell everyone else to go away. Well, it's just not going to happen, is it? When you've got a demanding baby, you're depressed, you might have other toddlers. So we do relaxation on the run. So all the time we're keeping in mind that it's the symptoms of depression are, for example, difficulty concentrating, where when you've got an infant as well, it all becomes so much more complicated. And so we begin with behavioural tasks, trying to increase pleasant activities, and then go on to trying to challenge some of the thinking underneath and some of the how this has come about. We actually, right from the beginning, bring the family in, and right from the beginning of unrealistic parenting expectations, we all bring with us our own parenting models. And sometimes they get in the road, they're not that helpful. And we include fathers or partners in at least 3 sessions. And what we're really excited about is that now we've actually translated this program, which is available for psychologists to roll out in private practice, for nurses to use as well. But now we've translated it over 8 years to an internet depression treatment. And oh, goodness me. Sorry, Andre's got the automatic. If you talk too long, it's saying move on. We want to get to the next slide. We've tried to make it as close as possible to face-to-face CBT. And we've also brought in another feature so that for those who score high on the Edinburgh, we have a coach, which isn't a therapist. It's someone who can help engage mothers and who can help them use the program. I'll just give you a little bit about the research. We started in 2013 with a feasibility study, found excellent results. 2016, so a randomized trial together with our US colleagues. And our latest research is in 2021. And we've been able to show, and we've just published, as you can see, 2021. Oh, sorry. There's some automatic timing going on here, which is faster than I can manage, that it performs at least as well as face-to-face CBT. And that is just really, really exciting us. And now we've actually rolled it out in the real world. We've actually attracted Department of Health funding, and now it's available to you all. You can refer women, and we are finding the same improvement in depression, in improvement as we did in our treatment trials. So it's a real research translation to practice win, and it's available to you all, and I'll show you the link in a moment. This is what it looks like. It's visible on PCs, tablets, phones, and
you've arrived at session 1,
there you go.
The first of a 6-session MumMoodBooster program. We know that many mothers with new babies can have difficulty finding the time to use the web program, as well as making changes to your everyday routine. It can be hard to put yourself first, but by doing so, you will be in the best position to manage all the demands of motherhood. One last point before you get started. Please take your time, about a week, to work through each of the 6 sessions. They're really
Yeah, so you can see by having a host, we're trying to bring in that personal element. We have mothers sharing their vignettes, and it's very personalised, where women can store what they're doing in their own workbook. The program looks a bit like the face-to-face one in that it's got, again, you know, the sessions around pleasant activities, positive thoughts and so on, but it also has a series of library articles they can go to. It also has a partner website to invite their partner to, and their partner can't see what they're doing, and they can personalise their own ongoing progress. Sorry, this is a bit annoying. So that's really what we've done, and what's really great is we can reflect their progress very easily in pictures, and we can animate, for example, the depressive spiral. So this is an animated presentation, which usually you describe how when you're depressed.
A key point in this program involves the way that your mood can become worse through a series of what feel like automatic reactions in a downward mood spiral. Typically, you start out experiencing a difficult situation. Then you have a negative thought that may be about yourself, the world, or your future, which makes you feel bad. You may feel depressed, anxious, frustrated, or any other unwanted feeling, which then affects what you say or do.
So you can see that we animate the message of what we're trying to get. And if you want to go to MumMoodBooster, you can go to our URL, or you can go to Health Pathways, and you'll find it under online therapies. So this is what MumSpace looks like, the website that houses MumMoodBooster. And I'm going to tell you a little bit about a special GP and clinician portal. We're delivering a digital step care approach where we have a number of tools, including MumMoodBooster. So it's very much a step care approach where women can go and browse around, find things to support their parenting, and then if needed, go further up. But the new feature, which we'd like to share with you, there's the URL. There's MumMoodBooster on MumSpace. There's some of the apps that are available to help mums with tips, positive thinking, some of the parenting support, and there's some stats. We've had 110 visits to the website, and we've treated 6,000 women with the internet programs. So this gives you an idea of how you can integrate it into your treatment. If you think a woman has depression, anxiety diagnosis, then you can refer her on to. Our research studies were for women with a clinical depression. But the new feature is our portal. Our portal means that you can refer women directly if you want to, rather than having them just go to the website, which they can. If you refer them with their consent, you can actually track their progress, and you can actually make it part of your own treatment. It's secure. You'll get an initial assessment of how the mum's doing on a number of depression scales, and you'll know if we've had to send a mum a risk alert. You'll be able to go to our database should you want to look at 1, 4, and 8 week of how she's doing. So this is a way of making it, a mum can go directly without your involvement, or you can use it as part of your treatment. So it's a simple, we think, framework, and registering for the account is incredibly easy. I'll show you what it looks like. You go to the clinician portal on www.mumspace.com.au. It says, do you want to register? If you want to register, you just put in your details. Here are your details, and you're in, which you give us your APRA number, and then you have access to the dashboard. And you can see what the mum has screened on the DSM-5 screener. You can see whether she's received a risk alert. You can look at activity at any time. And it's really your tool as much as ours, we hope. So I think that brings me to the end of the presentation, because we wanted to allow plenty of time for questions and answers. We wanted to come back to Natasha. We wanted you to be thinking about which, what would you do with Natasha? Would online resources be suitable? What else might you do? And I think that is my last PowerPoint, and we can now have questions and answers, I think. I can keep having Natasha up to start the conversation if no one has a question yet, but Hamish, I'm going to hand over to you to facilitate this, and I'm going to move us out the way. Yeah.
Thank you very much, Jeanette. Look, we have had a couple of people comment on the case study already. We've had a couple of people believe that this would be a moderate risk, as well as one person with a high risk with question 10 in mind.
Thank you so much for everyone who's contributed in the chat with their thoughts. Jeanette, I wonder, you're still in control of the slideshow, if it would be helpful for us to come back to the slide which was managing immediate risk, just to provide some context around where this risk profile would sit. So it will be my second last slide. Yeah, so the managing immediate risk, just above that. Perfect. So I thought, thank you for the responses. I could see those as we were thinking about that. We do have more information on the case study that was provided in addition to the slides, and I'm not sure if everybody has had an opportunity to see that information. But when we are thinking about just the screening information that we have, we know that there is an indication of risk there. So thank you so much for alerting us and using that when we're thinking about our clinical judgment. We're then going to ask these questions at the start to get more information about where that level of risk would sit. So within, I don't know, Hamish, if you're able to confirm whether there was access to the case study or not, or whether it would be helpful for me to talk to that.
So I believe everyone has been sent the case study already, but Michelle, it might be, people might appreciate having it, access to it again though, in case they don't have it with them.
I think Michelle, sorry, Hamish, if you just expand on what.
Yeah, so I'll just talk to what we've been able to do. So within the case study, we've presented it as we've been able to go through the questions, and I'll just read out the section here to help inform us. So with the risk assessment, Natasha has thoughts of wanting to have her life return to pre-baby status. She reported vague, fleeting thoughts of not wanting to be here, but denied any intent or plan. She denied any thoughts of deliberate self-harm. There was no previous history of thoughts of self-harm as a teenager and no prior suicide attempts. She denied any thoughts of harming Audrey, and the mother-baby interactions were attuned and protective as well. So with that information, I wonder if we can get a sense of where we think that might sit across these three. And we can unmute if that's easier, if anyone wants to.
Anyone wants to unmute or video. This is a free for all now. Yeah. Michelle, so why don't you just
yeah, so I'll just clarify. So we've got the fleeting thoughts of self-harm, but no current plan or means. So we would actually have that sitting in the lower risk category once we've got that additional information and doing the risk assessment. So that's where we would be taking these steps in terms of thinking about supports and treatment options for Natasha. So any other questions, please feel free to pop them in the chat in relation to that if there is any queries.
And maybe just to expand on that, so I think that yes, it could have become moderate, as somebody had put in the chat. You know, should she have given anything else in these questions here, either, you know, recurrent thoughts with a plan and some thought about the means. So it's the fact that they were fleeting thoughts, and it's really hard, isn't it? Because you don't want to miss anything, and you don't want to say, oh, someone's low risk. So you should always be, you know, follow-up consultation based on your clinical hunch. Yes, I think she's low risk, but I'm not sure. I think I'll make another appointment and follow up.
And I think it highlights the screening tools in combination with the clinical judgment and the risk assessment questions that we're asking to get that sense of what that looks like.
So Hamish, is there, and it was very hard because I've been doing the slides. I haven't seen the chats. Alan, is there any other, or Michelle, are there any other questions?
I think someone asked about screening protocols for fathers, Jeanette. That was something they'd like to have found out a bit about this evening. Did you want to say?
Well, I think we can have a dialogue, Alan, because as we know, that's still an emerging area. So the Edinburgh, I'll start, and why don't you add?
Sure.
The Edinburgh has been used for fathers as well.
Yeah.
And there's some information that the cutoff may be a little different, but it seems to be used as a screener as well. One of the things that we do know is that they're not often screened, and there are now some efforts to roll out screening more nationwide with some perinatal mental health funding from government, which is the same funding that has funded us. And yes, our programs are free, which is amazing, and to include fathers. So I'm not sure that there's protocols as such, Alan. If you know of any, it might be that you can let us know some of the latest in that area.
I think you've covered the current status. The EPDS is probably what's being used most at the moment, with men also. The clinical practice guideline in Australia will be updated soon, so we'll watch that space and see if there's any development there in identifying perinatal mental health problems in men.
Great.
We have had another question come into the chat just now. So someone has asked, when family members think PND will just go away with time/hormone change, how do we challenge this belief and ensure participation in treatment?
Yeah, that's a good one.
Like to answer that.
So this time, Michelle and I will go in tandem. I'll start and Michelle will add, you know, because I think it is a challenge. I think that this touches on not just the belief it'll go away, but maybe stigma as well, maybe a lack of understanding of some of the all mums are tired, right? But trying to make a distinction, and education has a place here. There's a difference between just feeling tired because you've been up all night, your baby hasn't slept, to when you actually do the diagnostic assessment and you see that someone has that syndrome of symptoms, that becomes different. And so there's some psychoeducation about differentiating and helping. And sure, depression does eventually go away with some, it's a self-remitting condition with some women, but it takes a long time. And I think it's more trying to address, well, let's deal with it, because there's no point experiencing this terrible feeling. The other part of it is, you know, hormone. It's just biological. Well, you know, obviously there is an element of that. You know, there's been a huge upheaval, but as far as we understand the biopsychosocial model of depression, that is insufficient to explain postnatal depression
On a population level, yeah. It's
at a
not,
population level.
it's
Yeah.
not, there is an association. It's not
Yeah,
actually as huge a one as we've traditionally been believed
Yeah.
at a population level in terms of the whole burden of disease caused by perinatal depression.
Exactly. So I'll hand to Michelle, but I think it's both psychoeducation, but also dealing with maybe someone wants it to go away, doesn't want actually to identify that I'm depressed and what that means and the stigma and what might happen. So Michelle, over to you.
Yeah, I think it's a really good question because it highlights that this is still, unfortunately, a problem that's happening within community in a lack of awareness and understanding. So I think for this question, it's thinking about who are we in this role? Do we have a rapport with this client, or, you know, is it the client that is having these concerns or their family? But I think we start with a place from empathy because they're not alone, and we can do a bit of myth busting together in what are some of the common misconceptions, while Jeanette has highlighted then being able to talk about what we do now know, which is that it's not that hormones don't have a role, but it's actually we're complex beings, and it's a biological, psychological and social components that influence our mood. And it can be empowering to know that we actually can take steps then to create change for ourselves with that in mind.
And how common it is. I think that's often a relief, like you're not alone. You know, like if you're sitting with a group of mothers, you won't be the only one. Alan, you were about to say something?
Just what pops to mind is that Jeanette and some of our other clinicians developed, in fact, an intervention, a motivational interviewing intervention to overcome some of these help-seeking problems, wherever they're coming from. There's a reluctance to actually engage. Yeah, I don't know if you want to say anything about that.
No, thanks for that memory.
You guys are the clinicians. I'm not a clinician, but these guys can talk.
But you're the font of all wisdom. So thanks for the memory jog. So I guess that, as you know, motivational interviewing has been used in a lot of areas to help promote help seeking in more health issues like alcohol and so on. But and it relies on trying to help someone move to accepting help. And there's theories of change that you've probably heard about, but some women may not be ready. But they can be helped to move from nearly being ready, from the pre-acting phase to being ready through discussion and so on. And one of the very useful strategies, and when we adapted it to the perinatal area, is to appeal to a woman's values and what she wants, and through that, very often they can identify, I want to feel better for my baby, for example, or I just don't, this isn't the person I want to be. And through that, you can say, well, we can do something about that. We can help you get there. And
alongside that, I think too, if we're thinking about part of this question, I can see is ensure participation in treatment, having their voice heard and holding those concerns in mind while using motivational techniques. But we can actually test that out. You know, if we do create these changes, let's see if there's a difference in your mood. So it's empowering them to see, actually, does this create change for them as well?
Good point. That's nice feedback. Thank you.
Thank you, all three of you, for putting an input into that question there. I'll see if anyone else would like to put a question into the chat, or as we've said, unmute yourselves and ask away.
Can I say too, I noticed there was a couple of questions around MumMoodBooster, Jeanette, if it's free. I wonder if it would be helpful to talk about who can be on the clinician portal and who can have access as well. So that's clear for everyone too, if they're wondering about that resource.
Well, it's pretty straightforward answer, Michelle, as you basically anybody can access MumMoodBooster itself, and there's both a pregnancy version and a postnatal version, and so it's anonymous, and so we don't actually gather names. We will be doing more research on it and asking for consent for some people to participate, but at present, women can go there anonymously.
Free of charge, yeah.
Free of charge.
Yeah, and for anybody within Australia. Yeah, so nationally.
That's true, within Australia. And for anyone, now for clinicians to go to the portal, it's designed for clinicians with an APRA registration. That's whom it's designed for. And as you saw, it was absolutely simple to go there, and it happens within a few minutes and what's really nice is you get a code, and you don't have to do that every time you see a depressed mum. If you happen to be working with a population that, with that perinatal population and see a lot, that code will work, is your code that you give a mum, and it'll allow you to see the mums, any of the mums you refer under that code. So it links you with the mum. So we've tried to make it as simple as possible. We also love feedback, by the way. Like if there's things on the portal as you use it that you think, because it's new, gee, we'd really love that too, or gee, we actually don't want, don't send us, we tried to minimize the amount of information we send you back. Rather, you can go back if you want really detailed information. We don't want to overload you. So we'd love to know. Back to you, Hamish.
Thank you, Jeanette. Another opportunity, if anyone would like to put something into the chat for us quickly.